So we experience today a demographic shift. Since the FDA approval of LASIK, there has been around 40 to 50 million patients treated with laser eye surgery, so with PRK, LASIK, and now more and more with lenticular surgery. And this number is still growing. So in 90s, the average age of such a patient was around 30. So this patient, today we have 2026, are 30 years older. So they are either presbyopic or they have a cataract, and they need also another solution. And the solution is either refractive lens exchange or a cataract surgery. But here we face a problem of IOL calculation. And these people, they've been used of being glass-free, and I strongly believe that the wish continues, and they want to be also glass-free in the near. So around 10 to 15% of current cataract patients, they tend to have already treated corneas. And we know that these patients, as I said, they want to be glass-free also in the near, so they most likely choose also a premium IOL like EDOF or multifocal or toric lenses. So this is a challenge, how to calculate those lenses, as these patients expect a very good outcome. So when we look here at the schematic eye after refractive surgery, so on the left-hand side you see a virgin cornea. In the middle you see a myopic treated cornea, where we tend to, if we choose the standard formula, we tend to get a hyperopic outcome, and it's exactly the opposite. If we have a cornea treated for hyperopia, we tend to undercorrect the patient. So standard IOL power calculation formulas like SRKT, Holiday, or HOVR-Q were designed for virgin eyes, where the Gauss-Strand ratio is constant. So the relation between the posterior and the anterior corneal surface. And this ratio is around posterior to anterior around 0.84. After refractive surgery, we change the anterior surface of the cornea, but the posterior surface is untouched. So what is the solution for such patients? So if we compare the diagnostic, the topographical diagnostic of such corneas, when we just use the topography like Antares, we just have a super precise measurement of the anterior cornea. But if we want to measure the posterior cornea, we need to use an OCT-based device like MS39, and here we have a combination of Placido and the OCT scan, having a perfect anterior surface measurement and also the posterior one. So let's move to one practical example. Here we have a case, a 49 years old female came and she wants to have a treatment for her vision. She is currently +1.5. She didn't say anything that she had a laser treatment in the past, but having performed a scan with MS39, we see immediately that she had a myopic treatment, probably of 4 to 6 diopters. So I don't even need to ask her if she had refractive surgery. So if we choose a standard formula, what you see on the standard modern formula, which we see on the left-hand side, we would choose a +17 diopters lens. And here we have another options. We can, as we said from previous speaker, that if we turn on that this patient was treated for myopic refractive surgery, then this calculation changes plus to +18.5. And of course, the biggest or the most precise feature of MS39 is the ray tracing, where we see also the calculated lens power of +18.5. So you see an adjustment in order to avoid hyperopization of the patient. If we use standard formulas like Holiday or SRKT, so you see that we would also end up with a hyperopization. So instead of choosing a stronger IOL power, we would just use lower power lens. We have a very modern formula, so it was already told. So the PERL-DGS, prediction of equivalent anterior refractive lens. So it bypasses standard paraxial limitations using machine learning. and it was trained on thousands of eyes to learn the nonlinear relationship between biometric inputs and actual refractive outcomes. The EVO formula, emmetropia verifying optical, it's also a top-tier modern alternative. And it relies on the theory of emmetropization and general on an individual emmetropia factor. Those two formulas, they estimate, but we don't have real data. So what if we stop guessing and start measuring? And here with the MS39, we can really visualize the exact geometry of the cornea, of the anterior and posterior surfaces. It's called ray tracing. And based on ray tracing, we can trace individual rays of light through the exact all points of the cornea. We have the patient-specific anatomy regardless of previous refractive surgery, and then we can calculate the appropriate lens power. In the overview of the MS39, we have 4 formulas. We can also add the ray tracing, and resulting in more precise recommended IOL power, we can get a much more precise result, and it's very important for calculating the premium IOLs. So, and this leads to lower lens exchanges, because in some post-refractive surgery patients, we cannot make a touch-up because the corneas are too thin, or if we have still a thick cornea, this leads also to lower number of touch-ups, so a much precise solution. So the MS39 has also some other features, as we know. So we can measure the dryness of the eye, which is also crucial in calculating the lens. We can verify the thickness of the epithelium, so we can look if there are any epithelial regressions. We see also the tangential or the axial maps. We can see also the raw images of the OCT. And I think this feature is also underestimated between us. We should more often look in raw images in order to identify small scars or even mapped-up fingerprint dystrophy. In some cases, this needs to be treated prior cataract surgery. We can simulate the vision of the patient. We look at the corneal wavefront, and also very nice feature to calculate ICL, where we can simulate the predicted volt, and depending if the volt is low or high, we can change the size of the ICL. And here, as the last function, which I mentioned before, the option of the ray tracing IOL calculation. So in conclusion, treating post-refractive eyes requires absolute precision. Modern formulas in combination with MS39 ray tracing provides an unparalleled all-in-one advantage. And this device is the ultimate versatile device to analyze all types of corneas, virgin, pathologic, or surgically altered prior to cataract or refractive lens exchange surgery. Thank you very much.
Thank you. So, on a practical basis, how does that work on the machine? It's connected to the Pearl DGS to do the ray tracing?
Yes. You have all-in-one. So basically, after performing the biometry with the device, you get immediately 4 formulas. I can show it to you. And then there is another option that you can calculate the lens with ray tracing. And then basically what I do the screenshots. You can compare them, and you can see if they agree, if there's agreement or not. And then you can choose your IOL. It's a very nice overview.
Great, thank you.